어떻게? 김태훈 선생 환자는 잘 됐어? 괜찮아? 응? 아침? 김대훈 선생. 음.
Good morning to everyone. I am here, and today I'm going to present my EGM conference. Thanks for joining me. This is my case. 46 years old lady. She complained of recurrent application in her past medical history was unremarkable, and blood pressure is 125/75 millimeter mercury, and her BMI was about 16.9 to 3.3. This is the echocardiography. It was done at July 2025, and we can see normal size carrier chamber with normal global ejection fraction about 68%. And E prime is 9, and we can see fine clear. And this is the outside EKG of tachycardia. And this is actually ECG of normal sinus rhythm, and we cannot see the some pre-excitation. And this is the chest X-ray. Electrophysiologic study was done at 7 November 2025. This is the initial catheter positioning. And in this picture, two couripolar catheters were inserted at RV and Higgs, and polar catheter was inserted at RV, and CS or ablation catheter was inserted inside the CS. This is the initial rhythm of normal sinus rhythm. Sinus cycle length is about 747 milliseconds, AH is 60 milliseconds, HB is 58 milliseconds, and QRS duration is about 73 milliseconds. And we did RVP 600 milliseconds and earliest retrograde atrial activity at his 1-2 area. This is RVP 320 milliseconds and VA block cycle length. And also in this picture, we can see the VA decremental property by VEST 600 360 milliseconds to 350 milliseconds. And then we did RVP 320 milliseconds and VA block cycle length by RVP 320 milliseconds. And also EGM and single echo beat was seen by 600 330 milliseconds to 320 milliseconds. This is the AP block cycle length. And also, SAEST 600 to 20 milliseconds, we can see non-sustained atrial tachycardia induction here. The earliest atrial activity can be seen as the age 1340.
So, can we see the title top of the slide?
Yes. And I remove this. We did SAEST, and we can see EGM and single echo beat by 600 330 to 320 milliseconds here. And then subsequent atrial tachycardia induction by SAEST 600 to 20 milliseconds. And then we did SAEST 600 300 milliseconds and AV NRT induction occur. This is the narrow QRS tachycardia EKG at that time. Let me show the tachycardia cycle length in this EGM. The tachycardia cycle length is about 359 milliseconds, AH is 292 milliseconds, HB is 53, and QRS width is about 72 milliseconds, and VA interval is 14 milliseconds here. We did his respiratory PVC and no V reset was seen. This is my summary slide. In this case, we can see concentric retrograde atrial activation during RVP, and earliest retrograde activity can be seen at his area during RVP. And we can see via decremental property, and also we can see AHM and single echo beat, and narrow QRS tachycardia induced by SAES stasis and 220 milliseconds, and it shows V interval less than 60 milliseconds, and no V reset by his refractory PVC. And so this is my conclusion is typical AVNRT slow patch type. And this is the ablation catheter positioning, RAO view and LAO view. And this is the V4 radio frequency ablation signal here. And this is the signal during radio frequency ablation. And junctional rhythm occur during RF1. And this is the signal after radio frequency ablation. And also after radio frequency ablation, AT was induced by RAP 320 milliseconds. And earliest atrial activity is 8:30:40. Let me show tachycardia cycle length in this EGM. TCL is about 327 milliseconds, AH is about 75 milliseconds, HB is 53 milliseconds, and QRS is 77 milliseconds, and VA is 182 milliseconds. And also we did V overdrive daisy. BVI minus TCL is about 200 milliseconds. And we can see VAAV response here. And also we did delta AH, and delta AH during atrial pacing and tachycardia is equal to 0. This is my summary. Narrow QRS tachycardia induced by RAP 320 milliseconds, and earliest atrial activity seen at 8:13:40, and no V reset by his refractory PVC, and VAV response during V entrainment, and delta AH equal to 0. So my conclusion is AT originated from the RA mid-crystal terminalis. And also this is the ablation catheter positioning, RAO and LAO view. This is pre-ablation signal. And we can see a signal at ablation distance was 24 milliseconds earlier than the surface P wave. We did ablation at RA mid-crystal terminalis. We can see phasing at ablation distance also. This is after RF signal. And also, AVNRT was induced again by SAESD 500 to 260 milliseconds. Again, this is pre-RF signal for AVNRT. And this is during RF signal. This is post-RF signal. And we did program atrial stimulation using isopray, and then no induction, and no more jam, and no echo peak. This is the final EGM after radio frequency ablation. This is the dually EKG. Then at 7 November 2025. Thank you for your attention.
Why you tell us the atrial tachycardia was away from either crystal? Actual reading shows the SBC. It is really crystal. If you have a microscopic imaging, easier to estimate the location.
Yes.
Far away from it. So anybody describe it with crystal? Did I? Maybe not.
No.
I remember the
Yes.
it was from the SVC to sinus venous junction as well.
Yes.
I think we mapped by speedy. So unfortunately, this patient is a very small body size lady with a small right atrium, and it was very difficult to engage with chronic sinus by doing that contact. So the day before yesterday, we had this because the torsion of a field couple of catheter in the PSP case, not my case, but especially the small right atrial patient and pediatric patient both try to build a couple of catheter. So because we could not engage the chronic sinus, I put the ablation catheter in CS. Can you show us the first?
Initial.
And at the beginning of the
Is this the initial
Yes. That's why I put the ablation catheter to map the chronic sinus and conducted basic EP study. And at the beginning of the EP study, I saw the frequent unusual pattern of tachycardia mixed with AV node reentry. Can you show the induction electrogram? Oh, okay. Yeah. No. Don't move. Yeah, this
Yes.
one. Yeah. So this pattern was keep changing. But the final stable tachycardia was AV node reentry. But after slow pathway ablation, I tried to induce, and another pattern of tachycardia induced again. So that's why the remap. I thought it was coming from the septal tachycardia because septum his bundle was always but after mapping with the ablation catheter, it was higher. So we used the 3D mapping and ablated, successfully ablated from SVC and sinus venom area. But after ablating ectopic atrial tachycardia, I could induce the ABNRT again. So we delivered the slow pathway ablation. Please comment.
Let's go back to your case first. Oh,
No,
comment, please. No,
I
you use.
the question.
Yes, please.
With your tachycardia number 280, did you use only the single mapping catheter only? But because you saw the 3D map final version, but yeah, it's very hard to understand. So I think it's not with or without using 3D mapping.
Yeah, if you have a higher number of catheter and electrode, it's easy to find out the right focus there. Because this patient has small atrium, so I moved the ablation catheter from SVC, septum, sinus metal, hypophysis down there. We measured the earliest one, and that area was the lowest
Yeah,
one. So
I think it's better to present with the color map equation. Yeah.
All right, let's go back to your case.
very bizarre.
So this is just for the teaching for the fellows. Okay, this is very important now. So let's go to the history first. So what's a history? Okay. So you have a small body weight, is a 45 kilogram, but she's a relatively tall, 163 centimeter. So it's a very lean person. Okay. And then I don't know what's the reason in echocardiogram you had a diastolic dysfunction in this patient. But anyhow, that's the only abnormality you have, right? Okay. Show us the EKG now. So where is the retrograde P wave, this patient? Tell me, show me. You saw this case, so you should be able to tell. Lead two, point out where the P wave. Lead two. Yeah, right there. So for small body weight late, fast tachycardia, AVNRT, a little bit P wave, a little bit longer than RP interval than usually what you want to see. In children, for example, P wave will be inside the QRS complex. This small lady, yet RP interval a little bit longer than I like this. Okay, that's the first comment I have. But a P of X obviously appropriate for the AVNRT. Nothing really serious. Okay, let's go down. So sign of rhythm, PR intervals are normal. Okay, no other significant changes. All right, let's go. Next. Chest X-ray confirmed that. You knew that the patient has a small heart size, very pendulous heart. So Dr. Park already commented that the duodeca may not be a good idea for this. But anyhow, okay, keep going down. Okay, the catheter placement. Now, I have one comment for you here. What do you think about this RV catheter placement? You guys put an RV catheter any way you want to, whatever goes in, you study. Tell us. Not a good idea, especially when you're looking at SBT. Where do you think you're pacing here? RV. Tell me. What? What are you pacing? What do you have in the cardiac structure here? This area. After the East bundle, come what? Right bundle. Do not pace the right bundle in SBT cases. Go down to the intracardiac signal now. Look at the potential. RV distal. What do you have? Sharp initial notching downwards. What that it is? You're pacing right bundle. What do right bundle does to you? Conduction favorable to the East bundle, and then go up to fast pathway. So you remember your case when you did the V extra, there was no echo beat, no dual evidence physiology, because you're favoring anterior septal conduction. So fast pathway, all fast pathway. So you immediately want to put SVT cases far away from the right bundle. I don't care whether you put outflow track or in the posterior septum, low, you should not pace the conduction system, especially even WPW axillary pathway.
You mean this?
Distal, RV distal, downstroke, distal. That's yes, that one too. Yeah, that's the one. You shouldn't put it in there. Okay? So that's rule number one. I recommend you fellows to review article by Dr. Scheinman. Differentiation of SVT by pacing basal septum, posterior basal compared to the apex and septum. There's a well-written article circulation, so I want you to read those. It's important. Okay, next go. Go down. So you pace the RV. What happened? He says earliest, right? Clear? No question about it. So that's why you could not create the equity, neither the retrograde dual even the physiology in this patient. You're only able to induce equity antegrade conduction dual even physiology. So this is the first thing you need to learn. Okay, let's go down. Keep going. Keep going. And then you notice that the pacing also QRS complex, the surface is very narrow because you're conducting through the conduction system. Okay, keep going. And then A pacing, create the echo beat. So look at the after jump, there's an echo beat, right? Yeah. What is this activation sequence echo beat? Your ablation inside the CS, 3-4 proximal earlier. Okay. So it's important to remember this pattern here now, because we have a several tachycardia induced. So CS first, His bundle for next, and then HRA next, so on. Right? Agree? Okay. So HRA 1920 is the earliest. 1920 is in the septum, remember? Because retrograde, common or upper common going up through the fast pathway. That's a consistent with AV and equity. Okay. But look at the way the P wave will fall. Onset of a T wave, surface ECG. Come to the last bit. Yes, that deflection wasn't there before, you're there. That's so our EKG, clinical EKG, clinical tachycardia, AVNRT. Agree? Okay, let's go down. Keep going. And then you pace induced tachycardia. No, stay here, right there. So you think this is very aggressive pacing, or what did you do here? Why are you having this tachycardia? You're pacing channel 13, 14, it looks like, or 12, 11, 12, somewhere. And your duodeca catheter is all in the right atrium, I assume.
Yes.
Or you're pacing probably somewhere in the crista, lateral crista, mid crista. It is not uncommon when you pace very tight coupling in the crista induced this type of tachycardia. Because there is a crista, especially pectineous area, you have a lot of trabeculation, and then there's a lot of heterogeneity. Normal conduction system is dispersed quite a bit. So if you want to induce AFib, you pace crista area anterior to the crista, pectineal area, you can go a lot easier to induce AFib because of that reason. Okay, so this is a iatrogenic induction. Okay, good enough. Let's go. And you induce the pacing, induce tachycardia. Remember that you had the CS activations earliest. Remember that activation pattern we talked about? Consistent with it? Yes, it is. So it's AVNRT, no question about it. Okay. So it is, yes.
We can see the breakup of VA linking,
Right.
and cycling change.
A couple of bits,
Yeah.
yeah.
But the AVNRT, at the beginning of AVNRT, we see the wobbling phenomenon from time to time. So
Right.
is it common finding, or do we need to think about another?
No, it's common. Because your activation earliest stays the same except second bit. Second bit, not before. Yeah, that one. You think they're coming from the same source or your fusion? That's a fusion bit. So that could be some sort of a atrial activity going on because of your HRA 1920 is the earliest. You see that? 17, 18 became earlier. So you can see that because of onset of a junctional rhythm, first bit echo, your catheter can jump, move around because your cardiac contractile function change. So those are basically common type of picture you see. Because of the prematurity, your subsequent PR got longer, tachycardia cycle length, and then stabilized gradually. And then also you can see the same isolated PAC, very last bit. Last bit, yes. So it's an occasion you can see that. But a baseline CS tachycardia cycle length remains same. Okay? I don't know whether there's anything significant out of that thing we can do. Okay. Plus your duodeca is tightly squeezed into the right atrium. So maybe much more sensitive mechanical irritation possible. Okay, let's go. About that. Same clinical tachycardia, keep going. Okay. So key importance here that I want you fellows to know, your HV interval here should be same as the sinus rhythm or not? HV, I'm not talking AH, HV. Should be the same?
Yes, the same.
Right? Because it's important. If you had a node of ventricular pathway, this HV not going to be the same. Can early or can be late. So it is important for you to, when you study, make sure you have a good baseline HV interval and compare to during the tachycardia. But cannot be short, okay? Maybe slightly longer or same. So this is important finding. Okay, let's go. So you're looking at your first echo beat compared to your VA relationship here. What happened? It got shorter. Do you see here? Your retrograde A was falling into the onset of T. Now, where is it? Inside the QRS complex. So my question is that, is this the same tachycardia, different tachycardia? If not so, then what's the explanation for this? if a patient has the same echo pathway, okay, your BA conduction should be, RP interval should be the same. But it changes here. Even though you could not demonstrate multiple jump, this patient may have more than one slow pathway. So this is another important part that you notice that, okay? Because BA timing, even though is just activation relationship, but then your local EGM, if you look carefully, the same. Yet you have this RP interval change. So why we call slow fast, slow, and so on, relation to the R to the P, right? So that initial EKG that you showed to me could be slow EVNRT. This is a slow fast. Therefore, you need thinking about maybe there's more than one slow pathway. Okay? That's why he ablated how many AVNRT? 2 different tachycardia cycle lengths he ablated. This is the implication of this. Okay?
You mean the RP interval? The before one, it was
Longer.
Yeah, longer in the T wave, but
Yeah. Right there inside the QRS complex.
좀 이쯤에 있었는데
Right.
지금 여기.
So you want to measure that difference. More than 40 milliseconds, I bet. Okay?
원래는 이쪽에 있어요.
Right.
이거 원래
Right.
저 인덕션. 그래서 먼저 타키카디아가 돼요.
Right. So that means that difference could be more than 40 milliseconds. Then you need to think of multiple pathway. Okay? Yes. So first beat, subsequent warm up. What happened? Got shorter. So there's evidence this patient may have more than one slow pathway. That's why your tachycardia cyclist got shorter too. Okay? So slow energy tends to be slower than fast slow. Slow fast. Okay? That's what we're trying to tell you. Okay? Let's go. That's the reason I think you end up ablating twice this AVNRT slow pathway. Okay? And the tachycardia, second tachycardia was much slower than first one. Remember? Yes. Yeah, that's the whole thing. Whole story behind this. Okay, keep going. And you demonstrated very well maneuver-wise, A pacing, B pacing, extra, so on. AVNRT, remember, it exists by itself, doesn't need the atrium ventricle. Therefore, you cannot reset tachycardia, whatever you do. Okay? Keep going down. That's fine. Okay. Here, I have a comment for you. If you look at the aerial view, LAO view, I have a question about this cine. Look at the aerial view. Your his bundle catheter pointing up, right? And the aerial view, LAO view, barely see his bundle. It's straight up, right?
No, that is how the catheter.
No. Catheter going up,
Yeah,
straight up. That's his bundle.
Yeah.
RV coming down. I can see that. But the problem is that your ablation catheter also in aerial view pointing up. That bothers me quite a bit. You can tell where the AV node is this patient. Remember, heart is very slant. So AV node could be like this in his bundle here, AV node vertical. If you ablate there, there's a high risk of heart block. So always I tell you, do not point ablation catheter upward, horizontal or low. Never. The reason is that when you burn it, fellows, ablation energy goes forward, not at the site. Therefore, you really want to point down. Okay? You don't want to cause heart block. You may fail the procedure, but you don't want a heart block in 43-1. No. But luckily, if you look at the LAO view, my final comment is that look at the catheter where it is. Left toward his bundle. You see that? Because it's almost mouseable CS. That's why he had a good response. So in the left side, your his bundle catheter coming at you, ablation need to be left toward. Not same angle. Got a septal. But it's slightly pointing down would be better. But I wonder whether you took the same picture of this aerial view. So whether this view doesn't look like it pointing down, just pointing down. So anyway, okay. Keep going. Yes.
In this
Aerial view?
in the area view, if you do AVNRT on a very vertical
Right.
lady,
Right.
if the point does not have
Right.
that, it
right? Or horizontal.
It doesn't really like contact to the
The septum, you mean?
yeah.
No, that's the trouble that people misunderstand. When you have a vertical heart, you really got to get into the trapezius valve first, okay? And then you slowly rotate clockwise. That's why sometimes you need the sheet to support it. And what happening is that in vertical, horizontal heart, long elongated heart, this expansion can be much bigger than you think. Therefore, just by rotating first, the trapezius valve, and then you will see small, very small, sharp, small potentials. The ablation signal, can you show the ablation signal? Your first ablation? Your ablation signal, when this is before it, okay? Look at that. This A already too big. You got to be smaller than that, ablation distal. I would prefer that signal in the proximal electrode. Because even though there is some potential variation, because of the first sharp potential, can you see that? Ablation distal, yes, right next to following, there's a small hump, very small. That is most like a slow pathway, not the sharp one. Sharp is the local A already. So these patients, vertical heart, the space between the trapezius valve musculature, atrial small portion, and the slow pathway is very, very small. When the horizontal heart, you get more room to move around, but not in the vertical. That's why child AVNRT and the young, slender, long, elegant heart is more difficult. That's the reason. So your catheter has to be very, very slow movement. Okay. So looking at that hump kind of type, you think about it. Right posterior extension is not under the subendocardium. They course different depth through the trajectory. So in relation to the further depth in, you're going to see more far field, more blunt signal. In children, you can see easier because they're closer to the endocardium. Okay. But in adult, that typically does not happen. So this is what we have confusion. So a lot of people think a right port extension is a subendocardium. No, it's a mid-myocardium coming down straight. That's why often you end up going to roof of CS because of the course of deeper, those patients. And you are not able to find the potential typical site. That is a typical what we see. Okay, keep going. Go forward. Okay, you ablated. You had only one junction of beat. So what happened next beat? Explain to me. Why the QRS changed? Your His bundle timing different too. You see that? What do you think? Because your ablation catheter signal changed there too. Proximal. Look at the HRA proximal as well a little bit. Okay? So what does that mean? And your ablation proximal shows an R wave. This is a PAC from your catheter. Catheter moved there. So your catheter first beat, second beat, PAC from the ablation catheter. You need a subtle difference? It is important to watch when you're ablating this thing. You don't want to move a catheter move, okay? So that's why I think you had one junction of beat and then PAC, and then after that you don't show me, so I don't know what happened. But appears to be ablated.
What about the age 17, 18?
17, 18, let's see. Yeah,
So
the
this
better.
patient is another tachycardia. So
I don't know whether that's another tachycardia or
Can you line-
PAC. Line up, yes.
escape from slideshow.
But I don't think that coming from the high atrium, Dr. Park. I'll tell you why. You get the initially the Q, both 17, 18, 15, 16, Q8. Okay? That's a Q. Wavefront coming from somewhere else, not from the top. All right?
18 is
Initial wavefront.
bleed earlier.
No, the ablation junction. Your ablation even earlier. I'll show you. Go back to your slide. I'll show you. Ablation this time is a small noise as well, even earlier. I saw that. But go back to slide. The ablation signal. Ablation. Yes. No. Next one. Top third. No. Going down. You just had the ablations there, right there. Look at the ablation distal. Come back. Keep coming. Right there. Yes. There's a small notch there. Yes.
Slideshow.
Yes.
Slideshow, please.
I think it's coming from catheter. Yeah, right there. There's a noise there. That's even earlier. So proximal, distal to proximal. And then also proximal is R. Remember?
17, 18 is earlier.
No.
I think the line is over.
Yeah. But anyway. My eye tells me that the ablation causes PVC, PAC. Okay? That's why QRS changes as well. Anyway, it is important to monitor your ablation catheter signal.
Yeah.
Okay? Please do. Because if your catheter moved, there's no point to continue burning because you already catheter moved. Okay? But would be nice if you shown more junctional rhythm, then would be okay. It's a good ablation. All right, let's go. And then after that, you got all straightforward. Keep going. And then you induce just tachycardia. No, of course, stay there. Where was ablation? That was my question for you here. Still in the septal area, or was it still in the
I think I pulled back.
pull back? Okay, that's the only question I have. Because your ablation probably close already focused, okay? And she told you because mid crista because the activation early 13, 14, but then your duodeca are already entirely in the right atrium.
Yeah,
So electrode
because
location may not be
the
the
small RA
Right,
and the
right.
polar catheter covers from the high septum.
right. So clearly, wavefront breaking through between 13, 14, 11, 12 because of that positive, next one is negative, polarity reverse there. So therefore, between the 12, 11, 12, 13, 14, that was a focus. Okay, keep going. And I have one more last comment for you. Ablation of tachycardia. Show me. Ablation signal. Okay. So you got SBCRA junction, yes, most likely because you're looking at the height. Okay, keep going down. EGM. Okay. Now, my question to you. One major ablate here. Let me ask you this question. Now, this is for the fellows. This question is for fellows. So if you look at the ablation distal, it's a QS. Ablation proximal is RS. Why did you burn here? Would you burn here? Or would you pull down a little bit and ablate? Answer is probably pull down a little bit, ablate.
Yes.
Better. And then I think it would be nicer here if you display the unipolar. All right? So next time when you think it's a focal tachycardia, you really want to see a unipolar, distal tip and electrode 2, and then bipolar ablation, and look at the activation sequence. And your bipolar should be like the proximal RS, okay? And the unipolar electrode 1 should be QS, same time. That is the focus. So I would ablate at the proximal side, not the distal. That's the only thing that I have a comment for you, okay? Otherwise, luckily patient got done well. That's great, okay? Any other comment from anyone else, please?
I have a question.
Yes.
The senior doctors say there in patient with ABN autism, some patient has intermediate pathway and multiple slow pathway.
Yes.
But actually, there is no defined clear slow pathway.
Right.
It is related to conduction complex fiber orientation. Also, the connection species are different in that area. So how can we differentiate it? Is
I
it
don't know whether
conduction velocity change difference or just the anatomical?
No, I think there is a distinctive problem. We don't have a definition yet. Would be we have a good definition about the compact, the right rep or the posterior extension and so on. Between two is a missing puzzle, very small portion of that atrial tissue. But then a lot of argument exists, maybe physical distance between the leftward posterior extension, rightward posterior distance. Because the rightward posterior extension, there varies more than leftward extension. Therefore, if your relationship between the right and left between the septum get closer, maybe you have more connections and more difficult to ablate, and conduction would be slower because you have to go through longer tissue. But I don't know whether there's anything really histological human model that is shown. Even Igor Efimov does not able to answer that question. What is actually determining the exit site of an atrial connecting tissue between two mechanisms? Second question we have always puzzled about if you look at the, Anton Becker's paper, early days, only 15 to 20% have leftward defined leftward protection. Most of us have a rightward extension, but not the leftward. So the question is this slow AVNRT is the only people have a leftward extension, and slow fast would be only people have a no leftward extension, just compact node and then rightward extension. So this debate is still going on. None of us know that, sure. I haven't got from anyone clear answer. Even Sonny Jackman or anybody I asked them, but no one really knows. And Igor, explained that basically he thinks that's between the interposed HR tissue, fiber, conduction velocity, things like that. But I don't know the answer for you. No paper published on that regard. I've been trying to, get search for the answer, but no.
Another curiosity is we are doing the basic EP study in every single patient after AF ablation.
Sure, right.
And we see the dual physiology quite often.
Yes.
And it has been reported that 15 to 20% of general population has the dual physiology. But only few people shows this kind of SVT.
Right.
What is the difference?
I think my thought is that if you look at the epidemiology of AVNRT instance, you have early 2030s peak, and then they quiet. Another population develop 50s, 60s, 45 onward. I think the second group, least in my mind, they had dual physiology. The conditioning of the aging process, the other mechanisms of tachyarrhythmia, which mentioned atrial fibrillation, PVCs, as you know, fascicular VT, all those have a much higher instance of AVNRT. That maybe has to do with the retrograde feeding conditioning of the slow pathway by simply reversing the propagation map and continue. So if you look at the RVOT PVC patient, frequent PVC patient, they will have a far more dual nodal mechanism. And they often also have an AVNRT as well. So it is, I think it has to do with the reversal conduction fitting to the retrograde slow pathway conditioning also, I think is important. That may alter over the many years, ion channel remodeling, all this can happen. That's what we think. Now, early paper about the instance of dual physiology in general population is much lower than we know now. 50% no, far more than that. I think almost physiologic. I think that has to do with the technique, how they study the patient. If you look at the D'Amato paper or by the Andy Witt and all those guys, they usually always pace the higher atrium, which is favorable for fast pathway. But if you look at the study by animal model, always pacing more slow pathway area, more periphery, low crista, they have a far more dual physiology. So I think it's a competitive conduction. Therefore, where you pace, I think this matters. Similarly, where you pace a metric, we just saw today. So I think you favor one way or another. Like a more, I think, demonstration of dual physiology. So it is important that basically gotta pace the right place. Okay. So I think if you have a question, I would recommend the pace of right atrium as well as CS baseline study. Look at whether instance of induction and so forth. You will notice that the CS pacing much harder in AVNRT than higher atrium pacing because the impulse comes straight across the septum. Going to invade the fast slow pathway almost simultaneously, then you have no excitable gap. That's the reason. Only when you give isoproterenol and the rate, then only can be cut it. So those, I think, where the impulse coming from, it matters. I think it's cardiac issue. Okay.
My last question is: you are almost ready to submit the nodal
Yeah.
ventricular paper to Jack,
Right.
but thank you very much, including me as a causer.
No, I think
But
you-
honestly, I don't understand exactly
Mm.
how can we suspect nodal ventricular
Okay.
and where is the proper location of ablation.
Right.
Scheinman mentioned that just to ablate at the slow pathway area,
Yes.
but then what's the point?
That's the wrong, I think, and that's what we want to write a paper. Scheinman did the most patient with a normal structural heart disease patient, nodal ventricular pathway.
Mhm.
In our paper, as you know, we have Epstein, and we have very unusual left side insertion nodal ventricular pathway, and then also the last case we had on the non-coronary aortic cuspid node ventricular pathway. So I don't think this is all clear yet. What is but clearly the documental tissue involving pathway. Question is the pathway itself or whether insertion in the nodal tissue. And I think that's a debate. Nobody ever can prove a conduction velocity with axillary pathway anyway. Only we can see an endpoint result of it. When we ablate nodal ventricular axillary pathway, we don't see like a slow pathway axillary junction rhythm, unless you're ablating slow pathway area. Okay. So I don't think there is automatic tissue itself per se decremental. I think where the insertion is, I think it matters. So clearly, pathway insert in a subtile area close to the AV node area, and then pathway has involved decremental nodal tissue. I think that's the reason that you can separate complete out of EGM out of a tachycardia. So first thing you do, demonstrate that you can dissociate you from the tachycardia, but ventricle is a relation is 1-to-1. That would be suspecting nodal ventricular pathway. But I'm not sure whether you have a distinctive pathway potential or anything like that. We only seen two cases. Left side case with the pathway potential, and the aortic cuspid had the potential.
So when do we need to suspect potential nodal ventricle?
When you have a documental retrograde conducting pathway, that's one thing, especially when involving posterior subtle, then you have to differentiate two tachycardia. One is the PJRT, the other one is the nodal ventricular pathway. But PJRT is almost incessant tachycardia from childhood disease. The P wave is very distinctive, very long RP tachycardia. Nodal ventricular is not a long RP tachycardia many times. Could be intermediate, could be short. So that's one thing. Second thing is that PJRT is nodal ventricular. You can separate because the PJRT H is a part of the tachycardia circuit. Nodal ventricular is not. Simple as that. So you can do simple maneuver, you can figure that out.
So if the tachycardia is very similar to ABNRT, but the V extra beats reset the tachycardia, then we should suspect nodal ventricular.
And then you look at the HV relationship. That should vary. Okay. Nodal ventricular. ABNRT doesn't matter. Okay. Simple rule. So take it simple.
And how to decide to ablate at the right location?
Well, I think it is a matter of mapping, but we learned that is the left side nodal ventricular pathway. Some reason they develop more left bundle aberrancy, our luck. So then tachycardia get longer. Then it's not ABNRT. ABNRT shouldn't matter whether left bundle, right? And this tachycardia slow down. Then you really need to think this is left side nodal ventricular pathway. That's how we learn Myanmar case of a left side nodal ventricular.
Yeah. Then how to decide the right focus?
If you have a left bundle slow tachycardia, you got to map the left side septum.
But we cannot see the sharp potential like
the left side. You see, we have a tracing. Yes, you see potential.
Really?
Yes, absolutely. Retrograde A just before that, there's sharp potential. In the even right side, the posterior septum, we had the sharp potential, not A, but a sharp potential. So that's why Simon got very much interested in our cases. Yeah, I see. Because in their cases, they did not map really, I think, detailed enough to see that potential. That's what I'm thinking.
He already described that they cannot see the.
Yeah, that's right. Yeah.
Yeah.
So I think it's a matter of mapping a little more detail. You will find it. Yeah. And I'm almost sure with the single extra stimulus during the tachycardia V, AU map that did, you see even sharper potential. Yes. And then they can be slightly longer from sharp to the local A activation during that particular bit. So then sure that's an slow pathway. Yeah. That's important concept. That's how we found in the aortic cuspid tachycardia. Otherwise, we would not see it. So
let's be a nodal ventricular hunters.
But it is a fascinating tachycardia, but I'm not sure. And then there is, I mentioned earlier, Nina Chung is the first one actually described aortic cuspid decremental conducting axillary pathway. I think 2017, Nina Chung published a case of circulation. And she published a very interesting case, not the non-coronary cuspid, left coronary cuspid axillary pathway, antegrade conducting only decremental. That's the only case published I'm aware. So Nina presented that in that time Heart Rhythm Society, because I was in the presentation. It's very fascinating tachycardia, but nobody ever published anything else after that. clearly left coronary cuspid. You see the left coronary angio and look at the where was the pathway. Yeah.
Okay, nice. Any other
All right, gentlemen.
question?
Thanks so much for coming Saturday morning. Appreciate it very much. Enjoy your conference.
Thank you.
Learn more today. Great.